Good afternoon. I'm Philip Bendick, the Technical Director of the Peripheral Vascular Laboratory at William Beaumont Hospital in Royal Oak, Michigan, a suburb just outside Detroit in the southeastern part of the state. Today I'm going to be talking to you about venous reflux testing, the technique and interpretation of those studies. I'm going to talk about venous reflux testing today, but with a short introduction on venous thromboembolic disease, because as history has shown, it is not a trivial problem. There is a lot of death and disability caused secondary to the problem of acute deep vein thrombosis when it does embolize into the lungs and disrupt the pulmonary circulation. And again, it can be a fatal problem, most definitely. If you look at the epidemiology of this problem, each year there are roughly 1 million venous thromboembolic events, and about 30% of these are fatal, leaving over 600,000 non-fatal events to contend with. If you look at this compared to other commonly thought about diseases, if you look at heart attacks, for example, there are more venous thromboembolic events than heart attacks every year, and well more venous thromboembolic events than total strokes that occur each year. If you look at the mortality statistics, again, the related deaths from venous thromboembolic disease exceeds that of myocardial infarction or heart attacks, as well as stroke-related deaths, almost equaling those two combined in their annual mortality rate. Another way to look at that is each year, venous thromboembolic related deaths exceed the population of the entire state of Alaska. One way we look at such things in Michigan, and I am near the Ann Arbor where the University of Michigan is housed, is their football stadium, which holds approximately 113,000 spectators. If you fill that place up for 8 home games, you're talking about approximately the number of people in the United States who come down with venous thromboembolic disease every year. If you eliminate 3 of those stadium attendances, you basically account for the number of people who die related to venous thromboembolic disease every year. It just gives you a slightly different perspective on the significance of the disease. But the other factor that must be considered is the 600,000 plus survivors who then are at risk for chronic venous insufficiency or some form of post-thrombotic syndrome, and that's the group we wish to address primarily today. If you look, for example, at the annual incidence and overall prevalence of common diseases in the United States, coronary heart disease leads the pack at this point with a roughly 13.5 million, peripheral arterial disease, congestive heart failure, stroke, etc. But venous reflux disease supersedes all of these dramatically, with approximately 25 million people currently affected in the United States by some form of chronic venous insufficiency, abbreviated CVI. Again, deep vein thrombosis is the attention getter. It provides the glamour and the glitz in this process, and it's the one that gets people very nervous and worried. But one should not lose sight of the big picture, and that is really chronic venous disease, as that involves so many people. It also is a complex diagnostic problem in that it involves the deep venous system, the superficial venous system, and the perforating veins that connect these two systems. And these can be alone or in any combination, adding more complexity to the diagnosis for this. It comes in a lot of shapes and forms. If you talk simply about varicose veins, you're talking roughly 25 million people in the United States. Certainly significant, clinically significant swelling affects approximately 6 million. There are chronic skin changes in 1 million patients in the United States, and about half of these have actual skin breakdown and ulceration during any one year. The venous disease we're talking about is classified by the so-called CEAP system, where C is the clinical side. Is there pain, edema, ulceration, varicose veins, etc.? E is the etiology. Is it congenital, primary, or secondary? A is the anatomic. Is it involved the superficial, deep perforator systems, or some combination? And P is the pathophysiology. Is it a problem of reflux disease or venous obstruction, or a combination of these two pathophysiologic phenomena? And this then lets us standardize our discussions about chronic venous insufficiency. But if you look at the underlying pathophysiology, it is all basically a result of what is called chronic ambulatory venous hypertension. That is to say, when we are upright and ambulatory, the venous pressure is chronically elevated to the point that the veins cannot tolerate it any longer and the stasis changes start to occur. Another way to think of it is a simple quote from I'm not sure whom, but man made a big mistake when he stood up. And this is not a new phenomenon. Venous varicose veins have been recognized for a long time. This is an old Greek sculpture over in Athens in one of the older buildings over there. And there is actually a saint for varicose veins, Saint Peregrine. If we look at the venous anatomy, we have the superficial system right under the skin, and this is primarily the saphenous vein and some of its branches. And then we have the saphenous vein in its own compartment, and then we have the deep venous system and then the connecting veins that go there. The two superficial systems of primary interest are the great saphenous vein, which runs along the medial aspect of the thigh and calf, and the small saphenous vein, which runs along the posterior calf in both legs. There are a number of important branches and tributaries, too many to go into and name at this point, but they do exist, and any of these can become involved in chronic venous insufficiency. The perforating veins penetrate the deep fascia and connect the deep veins to the superficial compartments. The major perforating veins tend to be anatomically consistent, and in the old formatting, there was Cockett's group, which were the predominant ones just above the medial malleolus and at the level of the ankle, the so-called gator zone. There are Boyd's perforators just below the level of the knee, and Dodd's perforators in the distal thigh near the adductor hiatus and Hunter's canal. Those were the three primary groups people used to talk about. Now they talk about perforators of the thigh in the new classification system, of the knee and popliteal space, the calf and ankle, anterior, posterior, medial, and lateral, to give a more precise definition of the location of the perforator veins. And there are complicated maps that you can draw out of the lower extremities which demonstrate where these veins occur. But again, the prominent point to remember is the important major groups are anatomically fairly consistent, and those are the ones that, if any play a role, they are the ones most likely to be involved. In terms of the perforating veins, they come in two types. There's the direct perforating vein, which goes directly from the superficial system to the deep system. And then there are the indirect perforating veins, which connect via the saphenous system to the deep venous system. Normally, there are valves at this level and layer of fascia, right in through here. And the valves in the perforating veins are designed to only allow flow in a normal setting from the superficial into the deep system, not to allow flow out from the deep into the superficial system. And that's an important consideration to keep in mind when we return to the hemodynamics of the perforating veins. Their size is also a consideration. This is the deep fascial plane. This is the deep venous compartment. Here's the superficial compartment. And when you measure the diameter of the perforating vein at that fascial plane, they should be in the neighborhood of 2 to 2.5 millimeters. If they were all this large and this easy to see, they would all be incompetent. Normally, because they are small and have a limited amount of flow, color Doppler is the best way to look at them. And we'll return to this point later on in the talk. Venous physiology itself is also interesting. It is very different, obviously, from arterial physiology in that things don't happen very quickly. There's not a lot of heart rate pulsatility, but there are other variations in venous flow that one must consider. Importantly, the way the veins are designed with their valve structure is they are designed to allow blood to flow back to the heart. But if flow tries to go back down the leg, for example, into the lower leg, the valve closes and prevents that return or reflux flow into the lower leg. These valves are very small, delicate, fragile structures, however, and they can be damaged very easily, leading to chronic venous insufficiency when reflux flow is allowed distally. This is a short video clip that shows in real time a normally functioning venous valve. You can see it snaps shut when pressure is increased in this region, trying to force flow back down the leg, but normally they are open, permitting the rapid egress of flow from the lower extremity back towards the heart. That's a normal functioning valve, as it should appear. The other important consideration in venous physiology is the calf muscle pump. Normally, when the calf muscle contracts, it will constrict the deep veins within the calf compartment, and it will force blood flow dramatically and forcefully back to the heart. When the muscles relax and the veins are no longer compressed, the valves close and do not allow reflux flow back down into the lower leg, but the veins then have to fill through capillary filling in their normal channel, which provides a good effort from the calf muscle pump. If you look at it schematically, when the calf contracts a few times, you get a large degree of emptying, the valves function properly, there's no reflux flow, and the actual pressure in the venous system can drop 80 to 90% during that type of ambulation, just taking 2 or 3 steps. If you were to stand perfectly still and upright, a normal adult would have approximately 100 millimeters mercury pressure at the level of the ankle. But by just the motion of taking a few steps, the calf muscle pump empties that compartment. It fills up very slowly through the capillary bed. So during ambulation in a normal venous system, your pressure at the ankle is roughly in the neighborhood of 10 to 20 millimeters of mercury instead of 100 millimeters of mercury. And the ankle and the venous system can tolerate these pressures very nicely. So again, ambulation and walking is a good thing when the calf muscle pump and the valves are working properly. Venous physiology can measure all of this quantitatively using some type of plethysmography. You empty the leg with the patient supine, stand them up, and you look at venous filling time and the amount of flow that it takes to fill the calf. You then take a single emptying maneuver of the calf to see what the emptying volume is, and then you can take repetitive emptying maneuvers to see what the residual volume in the calf is, and again, then look at venous refilling with the patient or subject upright. This gives you a quantitative look physiologically at the function of the calf muscle pump and the valves simultaneously. This has been done historically with photoplethysmography. This is an example of normal emptying of the calf and a slow refilling through the capillary bed. The upper trace shows an abnormal response when you do not get as good an emptying and you have a more rapid refilling of the calf in an abnormal setting, indicating valvular incompetence and some dysfunction of the calf muscle pump. This test in this day and age can be somewhat automated through different types of testing tables and beds where the patient lies supine for emptying, and then the patient is just tipped upright very quickly, computer monitoring of the diameter of the calf and the volume of the lower leg in terms of venous filling and capacitance. It can all go wrong, however, very clearly by the number of patients involved with chronic venous insufficiency out there, and when it does, we need to make that diagnosis as accurately as possible. This is a normal vein with the valve open and closed. If you have a leaky valve, the valve leaflets cannot close properly or they have been damaged for some reason, then you're going to have reflux flows back down the calf. And here is where things get complicated in terms of diagnosis, because you have to evaluate for deep venous insufficiency, superficial venous involvement, perforator involvement, obstruction in the venous outflow tract, and is the venous calf pump working properly. All of those things go into a study, and they can occur alone or in any combination. The first thing to do when a patient presents for a possible venous insufficiency test, though, is basically turn on the lights in the examination room, stand the patient up to put their veins under gravitational pressure, and look at the legs to see if there are prominent varicose veins that stand out. This will be a guideline for where you need to use your duplex ultrasound system to actually get a complete and thorough diagnosis. And it may not just be the site of the great saphenous or small saphenous vein. It may be one or more of these tributaries and branches that we mentioned earlier. So standing the patient up and actually physically examining the leg and using a marker on the leg if you need to mark the path of these obvious varicose veins can be very, very helpful as the examination continues. The other trick in this is if you're going to test for venous insufficiency, it's best done later in the day after the patient has been ambulatory for some time. We did a study a number of years ago and looked at the size and the number of perforating veins that were readily apparent with duplex ultrasound, and found that later in the afternoon we could see on average 2 more perforating veins in each calf with an average diameter approximately 1/2 millimeter larger than it was at rest early in the day. So the perforating veins and the venous insufficiency will be more prominent later in the day after a day of normal activity, and that is the best time to do testing for insufficiency. Positioning of the patient is also very important. You need to have them in a relaxed position. A degree of reverse Trendelenburg is often sufficient. The patient does not often have to stand up to complete this test, but it should be at least 15 to 20 degrees. The head of the stretcher raised, that leg in a relaxed, externally rotated position. In the olden days, we used to do a lot of Valsalva maneuvers as well, but this has been found relatively difficult to explain to many patients. There's a variable amount of patient effort, and those lead to very poor reproducibility of Valsalva. It is much better if you can just have the patient take in a small breath and hold it, and then use manual compression, either proximal or distal, to achieve your augmentation responses for insufficiency testing. This type of instruction for the patient, just take in a breath and hold it, is easily understood. The patient is not required to put much of any effort into this process, and you get excellent reproducibility because the operator is now in control of the degree of augmentation response that they are looking for in the extremity. When you do look at venous flows, you want to establish again distal augmentation, which shows that there is flow back towards the heart. And then when you release that augmentation, there is reflux flow, indicated flow going back down towards the lower leg. This indicates valvular incompetence, in this case in the popliteal vein in the deep venous system. Similar testing is done in the saphenous system. This is the great saphenous vein above the knee, which again shows distal augmentation. And when that augmentation is released, there is significant reflux flow down into the lower leg because of valvular incompetence. Also applies when you see those very complex varicose veins that often occur as tributaries to the saphenous, and again showing the results of gravitational forces causing reflux flow throughout, in this case, an anterolateral branch off the great saphenous vein in the left lower extremity. If you think about valve closure times, the data out there very clearly suggests that in the deep venous system, it should take less than 1 second to completely close a valve. In the calf veins and the saphenous venous system, it should take less than 1/2 second. And in the perforating veins, because they're small and relatively short, it should take less than approximately 1/3 of a second. These are the textbook valve closure times, and any reflux flow measured longer than these times would be considered indicative of valvular incompetence. However, if you're talking clinical significance, basically an incompetent valve is going to allow persistent reflux flow that basically persists as long as the augmentation maneuver is maintained. In a case like this, you have distal augmentation in this particular vein, and when you release it, you can see the long, extended 5 to 6 second degree of reflux flow, indicating severe and clinically important valvular incompetence in this particular venous system, or certainly chronic venous insufficiency. Likewise, in the great saphenous vein, you can see the extended reflux flow here with proximal compression, and when that is released, there's flow back towards the heart, but the to and fro flow in the venous system indicates that incompetence. The calf muscle pump is an interesting phenomenon when this occurs. When you have primary varicose veins, just the saphenous vein is involved, but the deep system is normal. The calf muscle pump empties properly, but the incompetence in the saphenous system allows reflux flow to come back down into the calf and more rapid refilling. So even with ambulation, you only get a 40 to 70% pressure drop. So in a patient with primary varicose veins, the ambulatory venous pressure at the level of the ankle, instead of being 10 to 20 millimeters mercury, is approximately 50 millimeters of mercury. And this is what leads to a lot of the chronic venous changes, swelling at the ankle, changes in skin, and ultimately, in many patients, outright venous stasis ulceration. There's an old method of treating this, going back to the European days in the 17th and 18th and 19th centuries, called the Rindfleisch procedure, which clearly effectively isolates the saphenous vein from the rest of the circulation. But we have much better ways to treat this disease now, which are cosmetically superior. I'd like to refer back to this quote from Ruckley, who is an investigator in the United Kingdom, when he talks about venous disease, and he says that evidence-based medicine has not been so far a strong feature of phlebological practice, in that much of what has been done historically in treating and managing chronic venous insufficiency is based on past experience, but not necessarily on evidence and data. We do know for certain that the hemodynamic forces involved are first gravitational reflux. When you stand up, gravity wants to push that fluid back down towards the lower leg. Ideally, the valves prevent that, but not in all cases when there has been valvular damage. There are also cases of the perforator valves failing, allowing reflux flow from the deep system, as you can see in this case, out into the superficial system instead of the proper normal flow, directed flow into the deep system. So these two factors hemodynamically combine in many cases in chronic venous insufficiency. The best way to determine competence of the perforating veins is using color Doppler imaging with flow augmentation maneuvers with the legs hanging in some type of dependent position. Again, this is showing normally directed flow from the superficial system into the deep system through this perforating vein here, clearly demonstrated with color Doppler. This is another example of a competent perforating vein with normally directed flow. And you can see clearly the difference between a competent and an incompetent perforating vein just by the change in color. Here, red indicates flow from the deep system out through the fascial plane into the superficial compartment, indicating valvular incompetence in that particular perforating vein. You can use spectral Doppler to complement this, showing flow into the deep system and then out into the superficial compartment. But this is usually not necessary. The color Doppler imaging tells the story very nicely. The spectral Doppler, can be difficult doing augmentation maneuvers to maintain position of that spectral sample volume in exactly the right position to get this kind of spectral trace. And I say, it is usually not necessary. The color Doppler is certainly adequate. You will also get a feeling for whether the perforating vein is going to be competent or incompetent just by measuring its size at the fascial plane, looking at its diameter. If it's less than approximately 2 millimeters, there's an extremely high probability that it's competent. If it's greater than 3.5 millimeters, there's an equally high probability that it is incompetent. Between 2 and 3.5 millimeters is the transition zone, and there the vein does need to be assessed carefully and looked at with color Doppler imaging, particularly to determine the status of the valve function. Again, this measurement should be taken right at the fascial plane where the vein goes from the deep into the superficial compartment, right at this level, looking at the diameter to get some insight as to whether it is competent or incompetent, and then complemented with color Doppler imaging. One thing we do know, based on secondary to primary varicose veins, that perforator vein incompetence may develop over a very short period of time. You may see a patient today and they do not have an incompetent perforating vein. In 3 months they might return and the perforating vein may have developed incompetence in that very short period of time. Also, approximately 20% of patients with chronic venous insufficiency do have incompetent perforating veins involved with their primary varicose veins. It is also strongly associated with worsening clinical classifications using the CEAP system, particularly the classification going from varicose veins to stasis dermal changes to ulceration as the perforating vein incompetence becomes more and more involved in this process. Whether or not these failed perforator valves are truly clinically important is up to debate. In 1985 in the United Kingdom, a writer came out and said they were clinically important. 3 years later, another author came out and said, no, they're not clinically important. And the debate is still ongoing today. Again, remember Ruckley's admonition about evidence-based medicine and how we do or do not practice it. So, what is the etiology of perforating vein incompetence? Because that could tell us whether they do have a significant role in this entire process of chronic venous insufficiency. 2 mechanisms have been proposed. With increased deep venous pressure during calf muscle contraction, utilization of the calf muscle pump, that increased deep venous pressure dilates the perforating veins and causes them to become incompetent. The second theory is there is a volume and pressure overload at the entry point that is involving the incompetent saphenous vein, and because of the incompetence there, the volume and pressure in the superficial compartment overloads the perforating veins and causes them to dilate and become incompetent. So is it the deep system pressure increase, or is it the superficial vessel system pressure increase that causes that incompetence? Those are the two theories that have been proposed. Well, Nikos Labropoulos has done a lot of research in this, and I think has provided us with some very good answers to these questions. The first thing he showed that perforator vein incompetence was always associated with superficial venous insufficiency, particularly in the case of primary varicose veins. So when you see this type of primary varicose veins, there is going to be perforator vein incompetence oftentimes associated with that. He also showed in some studies that the perforating vein incompetence tends to develop, and again over a short period of time in many cases, either in a descending manner at a re-entry point where the saphenous incompetence enters back, the flow enters back into the deep system, or as the superficial venous insufficiency extends proximally in an ascending manner following that extension of the saphenous insufficiency. Also, we have seen in a number of published studies for treating primary saphenous insufficiency that the number and severity of perforator vein incompetence decreases dramatically simply by treating the incompetent saphenous vein. And these are just a few of the studies that have demonstrated that effect, showing a dramatic decrease in perforator vein incompetence just by treating the great saphenous vein in its insufficiency. So we do know incompetent perforator veins appear to be secondary to saphenous vein incompetence as best we can tell. And saphenous vein surgery for insufficiency improves the calf muscle pump function for when the surgery is for primary varicose veins. And again, it will improve all of the findings that we get objectively using plethysmography when we look at that calf muscle pump function. The other question remains is, what is the role of perforator veins when there's ulceration? When we reach stage 5 and 6 in the CEAP classification system, either active or healed ulceration, are those patients different in some manner than simple primary varicose veins and stasis dermal changes? Well, about 50% of venous ulceration is related to primary varicose veins. And again, it is rarely a complication of perforator incompetence only. So 45 to 50% of the CEAP classifications 4 through 6, which are the worst changes associated with chronic venous insufficiency, are saphenous vein incompetence. The primary varicose veins lead to incompetent perforating veins, and it's very likely, because so many of the perforating veins do become competent when the saphenous vein is treated, that these veins have any kind of significant role in venous ulceration when it is secondary to primary varicose veins. However, there is another class of patients with venous ulceration, the other half of those patients that have venous ulceration secondary to chronic venous insufficiency, which is often a result of the post-thrombotic syndrome. So when we look at the consequences of acute deep vein thrombosis, not so much worried about pulmonary embolism in this case, but what happens chronically when these veins start to heal? Well, then you have a combination of events going on in the post-thrombotic syndrome. You have not only valvular incompetence, but you have an obstructive component. And here, when the calf compartment contracts, the muscles contract and put pressure on the veins within the calf, the emptying cannot occur in a normal channel, and it is quite likely here that theory 1 kicks in. The increased calf pressure in the deep system dilates the perforating veins to the point that they become incompetent. It leads to secondary incompetence in the great saphenous and superficial venous system. And now when a patient ambulates and walks briskly, there is very poor emptying. There is reflux flow because of the incompetence, and the flow in the calf tends to be a back and forth phenomenon. And because now you're ambulating and exercising, arterial flow increases, and you can get actually an increase in ambulatory venous pressure at the level of the ankle. So instead of 100 millimeters of mercury, it might go up to 110 millimeters of mercury. And this is what can lead to these venous stasis ulcerations that everybody has problems dealing with. It's also interesting to note, if you look directly at the bed of an ulceration in these patients, approximately 70 to 75% of them will have very clearly an underlying associated incompetent perforating vein, indicating some degree of involvement in that perforating vein in the entire process. If you also look at management of these problems, if you have a normal deep venous system and you get venous ulceration which does heal, and you have surgery to treat the superficial insufficiency, the recurrence of ulceration is extremely low. If, on the other hand, it is post-thrombotic in the deep venous system and there is some degree of obstruction, you treat the superficial insufficiency with saphenous surgery, there is a high rate of recurrence of venous ulceration in these patients, even though you have treated the superficial component of the problem, if you have not treated the perforating veins. So how can we make all of this right? We have to keep in mind Ruckley's admonition about evidence-based medicine. So we do know in primary venous insufficiency, saphenous vein surgery is associated very strongly with the prevention of venous ulcer recurrence, and there is very strong clinical evidence that this is the case. We also know that in primary venous insufficiency, saphenous vein surgery will eliminate much of the perforator vein incompetence that we do commonly see in this problem. We also know that treatment of the incompetent perforating veins alone has very little effect on healing or recurrence of venous ulceration in patients with primary venous insufficiency, though again the level of evidence is not quite as strong for these particular patients. The treatment of associated incompetent perforating veins may be important to decrease venous ulceration in patients with post-thrombotic syndrome, however. We do not have a lot of evidence to support this contention, but the association of incompetent perforating veins with ulceration in post-thrombotic syndrome, the fact that ulcers tend to recur at a high degree in patients with post-thrombotic syndrome when the saphenous system is treated, is very different behavior than is seen in primary venous insufficiency. So there is evidence to at least suspect that treatment of associated perforating veins may be an important factor in eliminating the recurrence of venous ulceration in these patients. Well, I suspect my time is pretty much up at this point, so I'll be happy to stop and answer any questions. Thank you.